Okay, I think we can get started now. It is my great honor today to introduce a very good friend of mine and a long-term colleague of mine who I think is just wonderful, and he's doing such important work. We've been for years, I think a lot of us calling for in the literature, for the inclusion of Noma in other activities, and not just these isolated standalone studies. And it's amazing to see the work that Michael has been doing at MSF. He's the Noma epidemiologist at MSF in Sokoto in Nigeria, and he's been involved in several different studies over the years. And it's really exciting to learn today about how Michael and the team have been integrating Noma into other activities, which really, we strongly believe is the best way to better understand the distribution and the burden of disease. So welcome, Michael. I'm really excited about today's talk, and thank you so much for agreeing to share your findings with us.
Thank you so much, Ellis and INN, for this opportunity to present this wonderful work that we do at MSF. And I know most of the organizations who intervene in Noma disease have done a lot of surgery, and then we know that the attention is moving towards prevention from MSF side. And that is why exactly this particular work that I'm presenting is so important to all of us at MSF. So I would like to appreciate my colleagues too that have been able to join, and everybody who is working on Noma from wherever you are doing that in the world. So please feel free to drop your thoughts, your questions in the chat box, and then we will be able to talk about that later. Can you see my screen already?
Yes, we see it. Yes, yes, it's perfect. Thanks, Mike.
Yeah, yes. So, yeah, this is not a publication of a research study. This is more of a viewpoint article. And I'm going to explain how we got to a viewpoint article at the end of the day. But let me introduce myself again. My name is Michael Olaleye, and I'm the epidemiologist leading Noma research, leading the operational research agenda of Noma in Nigeria with MSF OCA. I'm based in Sokoto, Nigeria, where the Noma Children's Hospital, the famous Noma Children's Hospital, Sokoto, is also situated. So I will be presenting this today to inform us of what we learned during the integration of Noma screening into community campaigns that we did last year in Sokoto and Zamfara. Yeah. In 2023, we published a paper led by Ellis and the MSF team that's titled "The Proportion of Pediatric Admissions with Any Stage of Noma at the Anchor General Hospital." So we thought to pick a pediatric population and see what proportion of any stage of Noma came to the hospital, was admitted in that study period. The study period was 7 months. And at the end of the day, we were able to conclude and recommend that if we imbibe the habit of screening early, if we integrate screening for NOMA into our health services and into our community campaigns, we will be able to at least decrease the chance of patients developing into the advanced stages of NOMA. So as a matter of fact, MSF does not stop at study. We also try to implement our findings into policy and practice. And then we had to say, this conclusion from this NOMA pediatric population study, how do we implement it? And then the idea of screening, which we recommended ourselves, was brought to the table. And then we said it's a two-phase thing, integrating NOMA into hospital settings, just like you would, you're going to screen for malaria when a child comes to the hospital. We want NOMA to also be integrated into oral healthcare, into when the child accesses care at any hospital. The second part of it is to integrate NOMA into community outreaches such as vaccination, seasonal malaria chemoprophylaxis. And then in February, we had our opportunity to integrate into one of the programs of MSF. In February 2025, MSF had a multi-antigen vaccination campaign, which covered Wamako, Sokoto South, and Dangishuni LGAs of Sokoto State. And we wrote a proposal to integrate into this vaccination campaign. The idea was that the early stages of NOMA are reversible if they are identified early, and we set out to look for these earlier cases of NOMA according to the WHO. And like I said, we were able to integrate into vaccination and also into seasonal malaria chemoprophylaxis distribution. With this, we were able to address vaccination and at the same time address NTD. As you can see, these wonderful pictures, these are our staff from different screening rounds. So at some point, we had the opportunity to screen children at fixed vaccination sites, like the picture on my extreme right. And sometimes we moved from house to house, like the ones in the middle. This is the front of somebody's house, and the children were being mobilized to come outside. And you can see a NOMA screener performing his duty. So we were able to integrate in Sokoto and Gomi states, Gomi LGA of Zamfara State. The partnership was between MSF and the State Ministry of Health. The vaccination in itself had different, targets and different objectives. So in the process of integrating, we knew one thing. We knew that we were supposed to work with the plan of the vaccination without disturbing the effect, without disrupting their plans. So we wrote a mini proposal to be able to go to some of the vaccination sites that the vaccination team went to. And also in the SMC distribution, we could only join one round just to test, what we decided to do. So in Sokoto, we went to 3 local government areas, and in Gumi, we were privileged to go to all the 11 wards of that LGA. So in the first pilot, we had 3 teams with 3 nurses and 2 health promoters, data supervisor, and then myself, the epidemiologist. At the end of the day, we were able to screen around 8,000 children. I'll show you the data in the coming slides. We did 3 days training because everyone in this call should know that there's limited knowledge on NOMA. And then we had to train the community health extension workers because they were the ones closer to the community. And it was a good training because some of them had not even heard of NOMA before. So we did that in Wamako LGA, which is an urban part of semi-urban part of Sokoto State. And in the second pilot, we increased the capacity of the teams. We used 20 teams, and we used 3 CHUs per team. It was a bigger group this time around, same 3 days in Sokoto South and Dangishuni LGAs. And in the third round, we joined 90 teams. We did 90 teams, and we extended our days of training to 5 days because we also trained the MSF staff that were in that location. So for the screening group, we modified the screening group to be able to accommodate as many children as possible. So the vaccination age group was 6 to 59 months, 3 months to 59 months, in that range. But whenever we were in the house, the opportunity presented itself for us to screen more children than the coverage of the vaccination. And the process of normal screening is not that tedious, meaning that we could do more, we could screen more children while the vaccination team is still trying to get 1 or 2 children to cooperate. So we extended our gap to 6 months to 10 years so that we don't miss other children above 5 years that are possible to come down with NOMA. Our methodology was very quick. We had our gloves and our spatula, and we had our hand sanitizers to be able to do a quick check the mouth, of the gums, to see if they were bleeding gums. And so for a child who does not have Noma and it's very visible, you don't spend so much time, with just an oral examination of 1 minute, you are done. But if a case is, a little bit confusing, you want to ask for help, you want to check very well, you want to examine, you want to touch to see if there's pain, you could spend as much as 5 minutes there consulting your supervisor to confirm that this is a case. We all agree that Noma is a neglected tropical disease, not by mouth, but even in terms of experience and knowledge. So we designed a WHO grading aligned paper-based tool, which I'll show you towards the end of this presentation, and we put the we put it in Kobo Collect. Later, we switched to paper forms because the offline Kobo Collect was taking a lot of time. Very importantly, we couldn't have done the screenings and identified patients without having planned for those patients that were identified. So we said for the warning stage and the necrotizing gingivitis stage, they should be referred to the PHCs that are closest to them in the first round. But in the second round, we really wanted to see those children, and we referred them to the dental clinic of the Noma Children's Hospital. That was not sustainable, but at least we were able to see and we were able to get some success in terms of referral rate. But moving forward, we agree and we prefer that the warning stage and stage 1 should be referred to the PHCs closest to them because of follow-up. But the severe cases starting from 2 to 5 were all referred to the Noma Children's Hospital because we needed specialized care. So as you can see, this is one of the cases that we saw in the field, and this child was referred. This child was referred to the dental clinic of the Noma Children's Hospital. It benefited thanks to the team, the MOH team at the NCH Dental Clinic, who really supported this campaign very well. This child benefited from some scaling and polishing and had some other treatments at the dental clinic. Numbers. In the first round, we screened just a little above 1,000, and we got 15 cases, 15 confirmed cases. In the second round, was close to 9,000. We confirmed 112 cases, and in the third pilot, where we went to 11 wards encompassing the whole LGA, we screened over 20,000 children, and we got 539 cases. The interesting part of this is that we also found 4 advanced cases in this third pilot. So the more you open your bracket, you could see children of advanced stages. But we expect to see more of the early cases of Noma, which is our goal, to be able to halt the progression of the disease. And in total, last year, we screened over 30,000 children in 4 respective LGAs of Northwest Nigeria. So the less number, the better referral. In the first pilot, all the 15 children that we referred to the PHCs attended. We supported because we're also screening at those PHCs. In the second pilot, 98% of them accepted. Some families said they were okay, there's no need for medical care. But out of these 98, 56% reached the hospital, which means that parents do not see the early cases of Noma as a very dire case that they need to rush their children to the hospital. The health-seeking behavior around here is poor, just like you would guess or have studied from other research materials. If a child is not almost dying, people don't see the need to take that child to the hospital. And that's why we're able to not make good success in the patients that were referred coming to the hospital. In the third pilot, it was worse. We had 48%. I could say that is due to our own logistics because we had a referral nurse, but the referral nurse did not have the security. There were insecurity in some places, and he could not move the MSF vehicle into those places. And we had to do some remote management, which affected the number of children who were able to seek medical care. But importantly, in this third pilot, We saw 4 advanced stages, 2 stage 2, 1 stage 3, and 1 stage 4. And we sent them to the Noma. We sent 2 of them to the Noma Children's Hospital, while the edema stages were treated at the Gumi General Hospital. One of the highlights of this activity is that 14 children were seen in a particular house. One house, we got 14 stage 0, stage 1 children, and we had to that was an area of concern for us. It got us interested, and we found out that that house is a boarding school, a Quranic boarding school, the one that people in the north will understand as, Gidamala. And it was a success story in the sense that the head teacher at the school was willing to follow the children to the hospital, to the dental clinic of Normal Children's Hospital. They received care ranging from scaling and polishing to extraction and some other antibiotics. And they were really, really happy that they were able to get intervention from the Normal Children's Hospital. So what did we, so like I said, it's not a research. This is more like, what did we learn? Because we're trying this for the very first time in our community. We had some challenges which are not strange. We had some transport barriers. We had some stigma issues. And more importantly, parents, community leaders did not know what NOMA was. And our HP team had a stretch of time explaining what the disease is through different HP material, IC materials. This was the first time we're trying referring to a PHC. The PHC heads were supportive, and then we found out that this is actually sustainable to send these patients identified in these communities to the PHC instead of letting them travel all the way to town where the Normal Children's Hospital is based and spend a couple of thousands of naira. One very, very beautiful thing that we were able to achieve was the opportunity to train CHOOS. So MSF did not recruit daily workers, but rather MSF, in collaboration with the MOH, identified community health extension workers in that community to be trained and to perform these activities with some incentive. And the CHOOS were able to learn, and they were motivated to even screen at their facilities and send to us. And of a truth, some of them sent some early cases to us, some advanced cases of NOMA, which is a win-win situation for everybody concerned with NOMA by halting the progression of this horrible disease. So we recommended that it would be good to have PHC-based tools and training in the communities, because these tools are the ones, these PHC are the ones that are closer to the patients than people at the Normal Children's Hospital in Sokoto town. We had some community reception issues. Some parents were not interested in vaccination, and then that had a ripple effect on also the acceptance of oral screening. Some took the oral screening, rejected the vaccination. Some took the vaccination, rejected the oral screening. So, but we believe that there was a large acceptance of oral screening in the end due to strong engagements with the communities also. So we were learning per round, per pilot. We call them pilots, first pilot, second pilot, third pilot. We were learning and we were adjusting our model, if I may say. And then these are the things that we learned in the first round. It took a little time for the screeners to screen, but it took a whole lot more time for them to enter it into the Kobo Collect. Yeah, so in the second round, we switched to paper forms instead. In the PHC referral, we had some challenges with, how do I say this? As at the time some children visited the PHC, the staff were not there. And then, our management had to say, for the second round, let's refer to the Children's Hospital. Let's see the burden ourselves. Yeah. In the first round, we used 3 male nurses, but we learned in a very hard way, because the male nurses were not able to enter into the households like that picture you saw at the beginning. So we were limited to only children that could walk out themselves, or the ones that parents were ready to bring out of the house. But in the second round, we were able to introduce female chooks. We were able to enter into the compounds where males could not enter, and we were able to screen more. In the first round, we used nurses, which was not sustainable in terms of health policy, because we have limited nurses, or the ones that will be able to be in the community. So in the next round, we switched to choose, which was the more sustainable model. And we needed to support with confirmation of these cases. So we introduced a photo documentation process whereby you snap and you send to your supervisor after taking due consent from the parents. So what does this mean moving forward for policy, for research? We believe that if we can explore more opportunities to include NOMA into outreach campaigns such as vaccination, we've tried that, malaria, we've tried that. We look forward to integrating into malnutrition campaigns too. We believe that we'll be able to systematically catch these early cases and halt them from progressing into the irreversible stages of NOMA. And also the 14 cases that I mentioned earlier that we met in Quranic boarding schools, we also we were able to relate because there was a paper in Senegal that also mentioned the prevalence of this of NOMA in this kind of boarding schools. So as a project, we decided to add to our strategy to also screen children systematically in Quranic boarding schools in the communities that we serve. For the referral, we've been able to strengthen the PHC capacity by training the PHC staff and motivating them to join in this campaign against NOMA. We look forward to, in the future, developing contextual items, IEC materials, in screening materials in Hausa language that can help us to engage better with the community. And if we have the opportunity to collaborate with other NGOs that are willing to distribute oral hygiene kits, these are opportunities to enhance more community engagement and improve acceptance. So the tools that we used, we were able to follow the WHO grading, and we're able to devise these symptoms, we're able to label out these symptoms of NOMA and help the Jews to, how do I say, to convince themselves of the staging of the disease. I know there are health workers on this call who understand the staging of NOMA, but not every health worker have heard of NOMA, not to even talk of classifying them correctly into stages. So these signs and symptoms, when you take 3 to 4 years, you start to have a feeling that this is a case, and you can, it can guide you to make your conclusion, whether this is a stage 0, a stage 1, or a stage 2. And then we got some demographic data up there to be able to compare between age groups and then see the referral rates. So in conclusion, we're able to learn that NOMA screening we learned that NOMA screening can be effectively integrated into community health campaigns. It was not stressful. It was not non-invasive. There was high community acceptance, and we did not stress the other program. We did not stress the existing programs that we're integrating into. Also, we were able to learn that early detection is a worthy cause, and they choose being interested, being closer to the community at a vantage point to be able to help us achieve and halt the progression of this disease. And also, we're able to learn about referrals. We are still trying our best to ensure that we can refine and reform the referral strategies by involving the Ministry of Health, the CHUS, and the PHC at the grassroots level. And also the trainings that we've been able to do with different sectors, the CHUS, the PHC in charges, the data collectors, the health promotion, the community health extension, the community health educators, and then MSF team in Gumi. This is a lot of knowledge sharing that has helped more people to understand what the disease is and how best to prevent, refer, and treat the cases. So we recommend that this model should be scaled up in in high risk areas, in places where we have reported a lot of cases in the past. To be good to propose these to integrate into programs in these places. We're also recommending that the Ministry of Health and other NGOs can adapt this approach for sustainable impact. So I would like to acknowledge the MSF Sokoto project for taking the lead in this initiative, the MSF Gumi project for also allowing us to integrate into their SMC campaign last year, the Sokoto State Ministry of Health, the community leaders, Wamako LGA, Sokoto South LGA officials and leaders, the Dangeshuni ones too, and the ones in Gumi local government area. I must also say that in the process of screening, we've been able to meet with different stakeholders that have assessed what we did, and they feel like if they have any opportunity in other states, we don't want to do this only in Sokoto. We are open to other states, other countries. We are happy to share our strategy. We're happy to share the data tools. We are open for it to be refined for us to see how well we will be able to catch these cases early wherever you are in the world. So this will not just end as an internal report. We've been able to put together a 1,500 word viewpoint article. It's been submitted to Plus NTD already to share this lessons learned that we got from the 3 pilots that we did last year. And we've gotten our first revision. We hope that it will be published soon. And you can always have this information to try out wherever you are. And in case you would want to chat about how to go about it, my contact is here, and I would refer you to the medical team leaders that would be able to guide you appropriately on how you can also integrate normal screening into any community outreach campaign that you're doing in your locality. Thank you very much. Thank you for listening. I hope it was worth your time.
Thank you so much, Michael. That was really, really interesting. And, it's almost astounding that you actually managed to do an oral screening on 20,000 children. I mean, that is definitely, the biggest epi study that's ever been done. So I think, you and the team are doing such important work. And I already see there's questions in the chat and some raised hands. So I think we'll start with the question in the chat from Abdul Aziz. He says, great talk. Do you know if there are dentists at the PHCs or who's in charge of the management at the PHCs? And he also asks, can you speculate on any risk factors or predisposing factors not previously or commonly talked about? For example, in the house that you were mentioning, or the Quranic school, are there any peculiar features, especially protective factors for the kids not affected? Yeah.
Wow, that's I wouldn't say that's an excellent question. Those are excellent questions, and thank you so much for the dentist talk. I'm always excited whenever we have the dentist talk. I believe very well, and I've always communicated this with people that I interact with, that one of my goals is to as an epidemiologist with MSF is to involve more dentists in the treatment of Noma, not just oral and maxillofacial surgeons, because the future of eradicating Noma at the early stages really has something to do with dentists. So there are no dentists at the PHC as we know the settings, but there are nurses in the in charges are mostly nurses from my experience. And I think if they are trained on what to do, they would be able to do the right thing. And this does not nullify the fact that the best people to attend to these early cases are the dentists. We tried it ourselves. I don't know if Dr. Najib is on this call, but Dr. Najib and his team at the Noma Children's Hospital had their hands full during the second pilot, and they were able to even extend the treatment. Like scaling and polishing will not be done at the PhD level, but it was done at the dentist level of the Noma Children's Hospital. So we don't have the dentist at the PhD, but we recommend that stages 1 with plaque or need for tooth extraction can be referred to the Noma Children's Hospital, and the MSF will see that patient, even though he's not supposed to be admitted on bed, will support that patient with dental care and also any other IPD care if there's a comorbidity. For the risk factors in terms of the Quranic school, we in this context, we can relate with what's a Quranic school. It's a school whereby children are living with their teacher to teach. So they are not with their parents, they are with a teacher who provides Quranic knowledge to them. We know that these places does not have the best health conditions and also in terms of feeding, but I would say that we've not, from MSF side, we have not explored what are the factors in that Quranic school. And I think we can take a lesson from that to maybe do something in that aspect. Thank you very much, Abdul Razak, right?
Yeah. Thank you, Michael. Yeah, that would definitely be an interesting, factor for a follow-up study for sure, especially if we're going to be doing some screenings there. I see some more hands raised, so please feel free to turn your cameras on. Na Dickinson was the first hand raised.
Okay. Thank you very much. My name is Na Dixon. I want to say thank you to Michael and his team. You're doing such a great job, and I'm excited to be in this meeting today. I also heard in your presentation, oh, sorry, my camera is off. Sorry, it's not turning on the camera. So I also saw that you presented the referral acceptance for the first pilot was 100%, then it became lower on the second and the third pilot. What could be the factors responsible for that reduction in the acceptance?
Thank you very much. That's also an excellent question. So, of course, we are playing with numbers here. In the first round, there were just 15. We were situated inside the PHC. So it was easy for us to follow up with the PHC in charges to take care of these children. And we also followed up some days later to ensure that the child came for the appropriate follow-up. But in the second round, where we screened larger number of children and they had to come to the Noma Children's Hospital, there was the challenge of transport reimbursement, which we did, but some parents felt it was not enough. There was also the challenge of not taking it serious. This child is not running a fever. This child is not about to die. There's just gingivitis and, there's bleeding gums, blah, blah, blah. And they felt they could not leave, this health-seeking behavior question. They could not leave what they were doing to follow that child at that point. So in the third round, we implemented adding a referral nurse, but that also failed because we had a lot of places to cover, and security was also something else. But we are open to suggestions on how we could bring all these people to the hospital. I believe adequate transport reimbursement is like 50% of that. Yeah, but I think there's also HPIC strength that we can lean on to get these patients to the hospital. Yeah, thank you.
Thank you, Michael. I have another question, and I hope this is the last one. Can I go ahead?
Yeah. Go on, please.
Okay, thank you. So, would you like to consider displaced population, screening the children in the state population camp? Would you also like to consider, because I know because of the context, the security wouldn't allow you to go everywhere. Would you like to consider training third parties? We have these local NGOs who have access to other locations that MSF does not have. Would you like to consider partnering with them, training them, equip them with knowledge about Noma, and when they go into the field, they do the screening and report back to us. Would you want to explore this option?
Yeah, like, thank you so much. We've never thought of this in terms of getting training other people to go do it. But this is good, because the goal in the end is to be able to catch it early, screen wherever you have the opportunity to do it, be it in the hospital or in the community. So I'll take these points down and I'll see how to cascade it to my managers and see if we can try some. I think an IDP camp is also excellent because it represents the population that can be predisposed to having this disease. Thank you so much.
Thank you very much, and that's all from me. Thank you very much, and congratulations to Michael and your team. Thank you.
Thank you.
Thank you. Kenneth, would you like to ask your question? It's nice to see you.
It's nice to see my boss.
Okay, thank you so much. It's an excellent presentation, Michael. I see a whole lot has been done since I exited from Noma Children's Hospital. Yeah, we're a great team while we're there. So, again, it's a very nice presentation. I just wanted to point out on a few things. You mentioned that this initiative stemmed from one of the studies that was done in 2023, looking at the proportion of pediatrics coming with its representative Noma. It would be nice if you could highlight what the proportion of those pediatric cases where that's presented with early signs of Noma. I don't think I had what that proportion was. And then, secondly, the table you presented that had the 3 round and the findings, the numbers. Yeah, it's nice seeing numbers, but I think in addition, having proportions included beside each of the numbers gives us a more appreciable information. I think it might look more appreciable if the percentages of those numbers are included. And then I think you really hit it home when you mentioned sustainability. And I think that is the most significant thing that we'll do to really ensure that this program is sustainable. Thank God you highlighted the fall in the follow-up on referrals. 48% and 54%, I think. So what do you think we can do? Because, I mean, we know some of the PHCs do not function, so referring them to PHCs might not result in the good thing we want. Can't we institute like an on-site intervention? I mean, we know that antibiotics, nutritional interventions are key in management of early signs of Noma. Once it's suffice to be able to provide such interventions right there at the screening points, such that even if they are not able to eventually go for their referrals, they would have had some level of intervention and received at that point of intervention. Yeah, so I think besides that, it's an excellent presentation, and kudos to the good job you're doing over there. All that.
Yeah. Thank you so much, Dr. Ken. Yeah, like I agree with your recommendations on how the presentation could be better but more importantly, the sustainability is really what we look at MSF. We don't want to start what we feel that we cannot recommend to other people. In terms of the intervention, it's a welcome idea to be able to not just identify and maybe minimum level of treatment. It might be good also to provide some form of treatment plus incentive. Yeah, but we, like you said, we would. This is a good point. I would discuss it further, keeping in mind the sustainability. And also, one good news to say is that we are also doing another screening at the moment, where we are integrated into another vaccination campaign that started on Sunday. And we've added MWAC screening too. We want to know which proportion of NOMA cases out there are also malnourished, which is really, really good information that we can learn from it. And according to our plans, we should still be able to do 2 more screenings before the end of the year. So there's room for development, and we'll take your suggestions. Thank you so much. Okay.
Oh, thank you, Michael. Maisa, I do see your hand, but I'm just quickly going to take 2 questions from the chat, and then we'll get to you in just a minute. Michael, I'm going to read the 2 questions out. One is from Nigeria Epidem, and he's saying, given the poor oral hygiene observed in the remote locations, was there any follow-up conducted to ensure adherence to recommended oral hygiene practices and to assess possible relapse? And then the other question was from Abdulaziz, and he's saying, thank you very much for the response. I was wondering if it's possible for a dentist from the Noma Hospital to visit the PHCs, maybe once a week or a month, to do some of the required treatment. He says, I understand the chronic school conditions, but since some kids in the same school exposed to the same conditions didn't develop Noma, maybe there's something they're doing that's protective or some inherent factors at play. And once again, great job to you and the team.
Yeah, thank you, Alice. So for Nigeria Epidem, speaking about oral hygiene, we were able to identify, of course, some cases where a whole community had like oral hygiene problems. And like I said earlier, we were able to engage the health promotion team to visit those communities to do some NOMA sensitization, and more importantly, some oral hygiene sensitization and practices too for the people in that community. And I must confess that that was a one-off, but I feel like it's something. If we focus more on oral hygiene, we would downplay the other risk factors of NOMA. So that's why we would rather go into such communities doing NOMA sensitization until everybody knows that NOMA should be eradicated, and good oral hygiene is one of the components that makes that eradication possible. But we still have a lot of work to do with the health promotion team to ensure that they also reach their communities and let them know what are the risk factors of NOMA before talking about coming down with it or treatment. For Abdulrazak's Abdulaziz's suggestion, this is excellent. Like right now, I'm of a statistics background, but I wish I was a dentist as I'm seated here when it comes to NOMA. I have engaged with dentists in Canada. I've engaged with some dentists in Usman Danfodio. Dr. Bala is not a dentist, oral and maxillofacial surgeon. He has been a pillar of support, because these days I really want to engage with dentists, and I would be happy to see if they can be deployed, but I'm not the State Ministry of Health. We don't know if it's possible to support or to encourage this kind of deployment for dentists to visit, to be able to attend to these cases. I've also spoken, like I said, I'm in love with the dentist profession at the moment. I've spoken with the Dental Student Association. at Udut and at the federal level to encourage them to do Noma campaigns, and then they can be supported to be able to go into these communities. I even understand that there's a particular year of the dental school that you'll be posted to the rural communities. And if one of them is happy to lead this approach, I believe that one or two NGOs might be interested in supporting that campaign. But from our side and from my side and from MSF, the best we can do is just to speak about this to the hearing of the state MOH. Thank you so much once again, Abdulaziz.
Thanks, Michael. Maisa, please feel free to go ahead with your question.
Hi, thank you so much for the great work. It's really impressive to see like how many Noma cases was detected and lives that saved with your work. So this is really impressive. What I wanted to ask about, you've mentioned using this tool for the screening process. I was wondering, was there some kind of a threshold where you would say that this case will be included, or like just a simple gingivitis, or more like a swelling, or you had within this instrument a specific threshold, a case definition maybe that you agreed on with the investigators? It's very difficult to yeah, I think you have my question.
Yeah. When you do something 3 times, you definitely come up with this kind of questions. MSF is a multidisciplinary team, and then you see. So I've had these questions to cut the long story short, and my response was that we looked carefully into the WHO grading system, and we were able to develop an SOP that says that kind of simulates these conditions. Like I said, if you look at that tool and then you take bleeding gums, plaque, and then you talk about swollen gums, that is already like 3 years are already prompting you that this could be a confirmed cases of Noma. So we have not something like a model, but like an SOP that says following the WHO grading and making it simple by this data tool, with these signs and symptoms, you should be able to conclude at a particular significance level that this case is a stage 0 and stage 1. And as you know already, that the knowledge of the early stages of Noma is even difficult. We employed the attention of 2 of our MOH doctors in Noma Children's Hospital who are very experienced in this. I can't give them enough credit. Dr. Najib at the dental clinic and Dr. Surajo at the Noma Children's Hospital, who helped us to cross-check the cases through the pictures and then through some questions. So to answer your question in one sentence, we have an SOP which is open for collaboration and to put into a model for us to generally on an international level agree that this is a case definition for stage 0, stage 1, especially the early cases of Noma. And we're going to put it out there with the viewpoint article that will be published in PLOS NTV soon, and we look forward to constructive criticism to make it better. Yeah, thank you, Mason.
Thank you so much. Just a small thing to follow up with.
Yeah,
I'm not sure if you have the answer, but was this a little bit like very like sensitive? Like was it a very or was it very specific to Noma? What I mean is that were you targeting a simple gingivitis, or it needs to be like a specific symptoms with bleeding, more into severe phases?
Excellent question. Yeah, thank you, Mesa. Excellent question. So when we started the case, I had one of the doctors tell me, Michael, don't just bring me gingivitis cases. I need gingivitis with comorbidities. So if that helps to answer that question. So we got, like today, we saw cases of a child who already have loss of angle of the mouth, swollen lips, swollen cheek, 9 days fever, and bleeding gums without being irritated. So that's like, maybe I will give you that job to say that is a normal case, you know. So we understand, and especially the dentist will tell me I need the ones with comorbidities. But in the end, we don't just go for simple gingivitis, but we don't also play down on the gingivitis that does not have comorbidities in the community. We can discuss for that to strengthen how we classify these cases. Really open to discuss that. Thank you, Mason.
Thank you so much, Michael. Thank you.
Yeah.
Thanks, Michael. Okereke, I see your hand up. Please feel free to ask your question.
So thank you very much. Very well presented piece, Mr. Michael. So just a little comment, not a question. You know, some of these, just based on the WHO material that was used, proforma that was used, you know, sometimes they don't really capture the nuances that we see within the low resource setting. So I think that despite the recommendations they make, it needs to be adapted rather, accordingly with what is being seen in the field to make to bring out more robust findings.
Yeah.
Because when we get some of those materials, you see that it is being tested on more of the, you know, the global north, if I'm not mistaken, that's the western part of the world. So it may not speak to the matter of what is happening or we see in this part of the world and in low resource settings. So yeah, echoing with what Omara said, I think by the time you do some psychometrics on the document, we can boldly say that okay, these documents haven't been adapted from the WHO. It stands, it has stood the test of time and is reliable. Is a reliable piece that could be used for low resource settings, normal cases, or surveillance, as the case may be. Thank you.
Yeah. Thank you so much, Dr. Promise. This is very welcome. I agree with you. I believe even the experts in the dental and the dental field are really I'm even surprised that I've not had that question. I always have it every time about the stages 0 and 1. And I agree with you that we should match what's in context with what's in WHO grading. And that's why we debated about putting this piece out there, and we said it's okay. It's we are not just saying we did it. We are saying that we want it to be done better, and we are open to people reviewing our tools for us to make it better. So this is one of the materials that will tell WHO this is what is possible on the ground, you know, boots on the ground, and we believe this could, you know, spark up some advocacy and maybe get more dentists interested in the early stages of Noma, or let me say, get them interested in gingivitis, which is a precursor for Noma. Thank you.
Thank you so much, Michael. And I see a few more comments coming in, you know, saying thanks for the great presentation from Grace, and thank you for the enlightening and thought-provoking presentation from Emily. And are there any last final questions? We are almost out of time.
Elise, my own is am I free? Can I talk? Yeah, Michael, thank you so much. I really commend you for this wonderful initiative. Actually, you know, everyone is commending MSF for going into prevention rather than therapeutic aspect. My comment is just on the Quranic school, whereby I think I just want to respond to what Elise asked. I think it could be related to the fact that, you know, those schools are crowded, and if you could imagine IDP camp, so just the condition might actually resemble that of IDP camps. And you know, the sharing of these small resources, sometimes even water, You know, when those children wake up in the morning, even water to get water to rinse their mouth, they have to look for water actually. So the little resources they share, just imagine a condition similar to IDP camp is something that could be related to that aspect. But as Elise advised, I think maybe at a point in time, we need to actually explore more and see if we could come out with more risk, institutions. So thank you so much. This is just my contribution.
Thank you so much, Dr. Mara. This is very helpful. Of course, I'll reach out to you and we can see what we can develop from here. Thank you so much, sir.
Well, thank you. And please do, I popped Michael's email address in the chat, so please do get in touch with him if you are, considering doing a similar screening in your organization, or if you're wanting to learn more about MSF screening. I know they're very willing to share and get in touch and share their lessons learned. And, I think it's all of our dream to see this done in many more locations, because I think it's the only way we're going to get a true understanding of the global burden and distribution of the disease. So well done, Michael, for pioneering this work. I know it's not easy, and that is a lot of children to be screening, and you and the team have really done an amazing job. And so, yeah, just congratulations, and thank you so much for being willing to share your work with us. And I wanted to invite you all to next month's webinar. Alia Bly from Emory University is going to be joining us to share the lessons she's learned from Hansen's disease in bioinformatics. So that's going to be a really interesting presentation, and something hopefully we can learn about for use in Noma. So thank you very much to everyone for joining us. We will send out the recording. Sorry, Michael, I see one more hand raised. Abdulaziz, would you like to ask a final question and then we'll sign off?
Yeah, I'm sorry about that. Can you all hear me?
Sure.
So I was in a place that was noisy earlier, so that's why I had to type my questions on the chat. So yeah, great job. I think you've answered most of the question. The only comment that I had, which also speaks to some of the case ascertainment that was raised earlier, is did you at any point see if the case identification by the people on the field, did you check for maybe some agreement between what was assessed on the field and what the dentist at the normal hospital also ascertain using the pictures? Because I think that will be important in when you're trying to publish this this project. Thank you.
Michael, I think you're on mute. Sorry.
Look at me. Yeah, thank you so much, Abdulaziz. And I think I definitely have to reach out to you because you keep asking me very, very important dentist questions. Like I said, I've had my critics in the house, and that's why we were able to get to have some success in this screening. And one of the criticism is just what you mentioned, to be able to reconcile what the choose on the field think to what the dentists approve of a Noma case and its staging. And this is what we've done twice. It's not been easy, but we've been able to build a set of tools that we are using at the moment also to screen, which we've enhanced their knowledge, they've gotten better. And then we still have this kind of debates day in, day out to say that, oh no, the dentist thinks this way, the doctor on the ground thinks this way, and then the choose think this way. And then at the end of this, we all come together to a conclusion. So like I said, we are still open to learn. We are open to collaborate with more people. And from our side at the Noma Children's Hospital, I think we have a strong base to be able to push and develop ourselves more for identification and also for treatment of these cases early through community campaigns and also screening at hospital settings. Thank you so much. I would definitely reach out to you. Please, can you drop your contact in the chat box so that I can just follow myself? Thank you.
That's great. And that's what this network is all about, you know, connecting researchers and collaborating and working together. So that's really wonderful. And I think we'll end off with a lovely comment from Ibrahim Lawal. He says, I really appreciate how you broke down the concept into simple terms, Michael. It made it easy to understand and practical. And I couldn't agree more. And I think, you know, thank you so much for this. It's been really interesting. And we can't wait to hear about how this year's screenings go. And, you know, you're welcome back at the network anytime to present your findings. So thank you very much. And yeah,
thank you.
We look forward to hearing from you again soon. Yeah. Bye-bye, everyone.
Thank you, everyone. Thank you, Alice.
Bye.
Bye-bye, everyone.